Hello, hi. Yeah, my name is Dr. Nirmalkumar, Assistant Professor, Department of Anesthesia and Critical Care. Today, our topic is going to be inhalation anesthesia agents and the intravenous induction agents and some few drugs, benzodiazepines. So, mainly we'll be discussing about inhalation anesthesia agents and intravenous induction agents. So, what is the inhalation anesthesia agents? It's called as agents administered in a vapor form to the patient via pulmonary route to produce anesthesia. So the name says it. Inhalation anesthesia agents will be delivered to the patient via through the to the mouth, like inside the trachea, like the way, like after if it's a patient going to be a ventilated patient or after intubating, the patient will be having a endotracheal tube in his mouth, which is placed inside his lungs. So it will be delivered directly in that way, or it is going to be oral or like normal face mask or another mask. You are going to give a small anesthetic effect. We want to keep a nitrous oxide, then you can administer it through a face mask. Ultimately, it will go and circulate in the gas. It will take place in the gas exchange, like where the oxygen, carbon dioxide, the normal respiratory circulation, right? In that part, it will go and get circulated, and it will give the effect in the throat, like it will go inside the patient lung and gives the anesthesia effect. So it's a little bit about the history. The first of nitrous oxide is prepared by the Priestley in 1772. Or wells used in 1844 for dental extraction. The nitrous oxide was used in the time. And nitrous oxide, you all know that it's a laughing gas. Why we call it laughing gas? We'll discuss in the next coming slides. And the ether, it's also one of the well-known name for everyone, like as like nitrous oxide ether. Everyone knew that. William Morton used in 1846 for surgical anesthesia. I think it's a jaw surgery to remove a jaw mass. They used it. And halothane was introduced and discovered and clinically used in 1956 by Charles Suckling. And the methoxyfluorine was introduced in 1963. Enfluorine, 1973. Isofluorine, like the very recent, like 40 years back, like 1981. And desfluorine, 1992, just 28 years back, I think, like 30 years back. And sevoflurane after that, 1994. So sevoflurane is one of the latest inhalation agent, which is just introduced a couple of decades ago. And it's also a widely used one, this is sevoflurane. And desflurane, isoflurane, depend upon the patient condition and depend on the age group of the patient. For adult patient, maximum of the patients have no comorbidities. Patients, really stable patient, we use sevoflurane for maximum for all the patients because it's a really smooth and smooth expression. We can expect the patient to use under sevoflurane, but because it's a bit costly, patients who are not affordable, we will use isoflurane. And for pediatric age group also, we use desflurane. What is MAC? MAC is first term used by the Martel and the Eager in 1963. Yeah, minimal concentration called MAC. What are the types of volatile agents? See, all the volatile agents will be converted into gas. I mean, like gaseous state. Then we will introduce it to the patient. But the state, this is like a inertial agent. Normally, what is the nature? Like whether it's going to be in liquid state or something like a solid state and get evaporated, or semi-solid, or gas, or it's in the gaseous state. So these are the commonly used vaporizers. I mean, volatile agents, I mean, inhalation agents in the different form. Mostly it will be in a liquid form or in a gaseous state. So what are the volatile agents in a liquid form or ether, halothane, sevoflurane, isoflurane, desflurane, enflurane? Everything will be in a liquid form. As soon as it's open and just if you pour outside to the environment, to the if you let it to expose to the environment, it will just evaporate in a few seconds. So it will be stored in a really a good compact container. It will be filled in a way where there is no leakage. So it's more costly also. So it's a volatile but highly evaporative one. If it's going to be exposed to the environment, you get evaporated in just the full 250 ml bottle. What you're seeing the sevoflurane, it will get evaporated in just 20 seconds. Yeah. So the next one is nitrous oxide, cyclopropane, and xenon. All will be in the nature of gaseous state only. They will be in gaseous state, and it will be delivered as it is like that. But it will be all these gases like volatile agents won't be delivered individually, because it will cause more irritant, or it can cause even hypoxia. Sometimes maximum times it will cause hypoxia. Maximum times it will even cause many worse effects, and some of the volatile agents which tend to cause hypotension if it's going to deliver only solo. But so that's why the recent boils workstation, we can't switch on nitrous or gases like the sevoflurane, isoflurane, desflurane, enflurane. We can't individually deliver the gas to the patient. It will be combined with any other carrying gas like oxygen or nitrous. It will be combined mainly with oxygen. So oxygen will pass through the container and it will just carry that. So slowly it will get evaporated and will carry that. But even we can adjust the MAC value. So what we discussed, the minimal area concentration, we can adjust it. So we can keep how much it should deliver for this patient. So each and every patient, with the depending upon the weight and the comorbid condition, the vitals, we can set how much it should be delivered and how much is needed. Yeah, but each and every gas has its own MAC value. Sevoflurane has a 1.8, like that. Everything has its own MAC values. But nitrous oxide is the one which has the highest MAC value is 103. Yeah. Properties of an ideal inhalation agent. Yeah, as I said, it should be a cheap and easy to produce, but sevoflurane is comparatively more costly than any other volatile agents, but it's very good. Chemically stable and does not decompose on the exposure to light or interact with the soda lime. Yeah, non-inflammable and non-explosive. It's a real important thing. If it's going to be inflammable or explosive, it's very dangerous to use inside the operation theater because it's going to cause more harm to the patient, or even for us, people who are working inside the theater, for the surgeons or scrub nurse or technicians. They will be get harmed, like if it's going to use this kind of volatile agents in like this kind of properties. So please avoid those kind of things. So it should have a rapid induction and emergence. So as soon as you start introducing a volatile agent, it should act fast. So it's called a rapid induction. Patient should be knocked out, or patient should feel the creation, or for what purpose we're giving, it should achieve it fast. The purpose should be achieved very fast. Emergence, like as soon as you cut out, I mean, after you cut down the gas, it should be out fastly, and patient should go fast from it. So these effects should be, these properties should be, will say it's a really ideal volatile agent, and good for patients use. produce unconscious with some degree of analgesia and muscle relaxation. No volatile agent will give muscle relaxation. It will give very minimal of muscle relaxation and very minimal of analgesia. But it produces unconscious. Mostly it will cause unconscious. All the volatile agents will cause unconscious, but few of the gases have the property of giving analgesia, but do in a very minor part, not like a potent analgesic effort. It won't cause, it will cause only unconsciousness. Your conscious state will be knocked out by the volatile agents. So no serious or respiratory depression should be caused. No organ toxicity, should not undergo metabolism, should not trigger malignant hyperthermia. So malignant hyperthermia is a very deadly condition. We can't even manage that. Is there any malignant patient goes for malignant hyperthermia? It's very difficult for patient to revert back or to scare the patient. So please make sure patient should not end up in malignant hyperthermia. So this is the chemical structure and properties of the inhaled anesthetics. Yeah, for nitrous oxide, allothane, methoxyfluorine, fluorine, isoflurane, desflurane, and sevoflurane. As I told, each has its own molecular weight, boiling point, blood pressure, MAC value. As I said before, 1.822, sevoflurane has a 2 MAC value, and the desflurane has a 6 MAC value, and C is 6. On isoflurane 1.2, enflurane is 1.6. ISO 1.2, enflurane is 1.6, and CO with 2, and desflurane with 6. Nitrous has 103, 104. So is the highest MAC value. Allothane is 0.75. So it's the main things you should remember. MAC value for each and every tag. So yeah, 1.2 for isoflurane, 1.5 for enflurane, 2 for sevoflurane, 6 for desflurane, 104 for nitrous, and 0.75 for allothane. So clinical pharmacology of inhalation anesthetics, like each and everything, every gas is own effects on cardiovascular, respiratory, cerebral, neuromuscular, renal, hepatic, and metabolism. So in this, the least is nitrous oxide metabolism. The maximum is allothane. CO is 5%. So in this the desflurane and isoflurane has a maximum neuromuscular blockade property. Renal blood flow will be comparatively better in desflurane and the sevoflurane compared to many other drugs. And hepatic blood flow will be very much reduced in allothane compared to any other volatile agents. So this is the workstation where you can see a boils in the left corner and a fresh glass flow tube where it comes with the breathing circuit in and out, like you can see the circular thing in and out. So inspirator limb and expiratory limb connected to the electrical tube and delivered to the lungs, and they're mixed with the arterial blade goes to the brain, and converters to the blade and coming back and returning to the expiratory limb and back to the boils apparatus where it's entered the soda lime. So the CO2 will be absorbed in the soda lime. Uptake and distribution of inhalation agents. So you can see clearly it has explained how the alveolar ventilation and how the arterial bed is carried and how it distributes other tissues in the brain, and how it come back from other tissues to venous blade and passes through the lungs and the alveoli. and goes back. MAC is a common measure of the potential of the values are addictive. Immobilizing effects involves action in the spinal cord. At equilibrium, central nervous system partial pressure equals arterial partial pressure, which in turns equal alveolar partial pressure. Three factors affect uptake: solubility, partial pressure, difference between arterial and venous flow. Impaired concentration and blood gas solubility are the major determinants of the speed of induction. Sevoflurane physical properties. So clear, sevoflurane will be very clear, like a normal liquid, colorless, sweet-smelling liquid, not degraded by the light, preservative-free, not soluble in rubber, doesn't react with metals, react with soda lime to form a compound A. Non-inflammable, boiling point is 58.5. MAC is 2, as we discussed earlier in the form tube. And it has a non-pungent potent bronchodilator inhalation induction in both children and adults. Reasonable alternative to IV anesthetics here. The metabolism of sevoflurane results in inorganic fluoride, not associated with the renal concentrating defects. Sevoflurane is not metabolized through trifluoroacetate, does not stimulate formation of apps associated with hepatitis. Sevoflurane can form cardiac output, during exposure to dry carbon dioxide absorbers and can cause a canister fire via an exothermic reaction in dry absorbers. Sevoflurane also breaks down in the presence of carbon dioxide absorber to form a vinyl halide and compound A. Sevoflurane, the compound A, undergoes a basal catalyzed degradation in carbon dioxide absorbance to form vinyl ether compound A, enhanced in the closed circuit, warm dry carbon dioxide absorbent and the low flow anesthesia. Compound A cysteine conjugates to toxic fuel. It causes mainly renal injury, which is proven by studies in the rats. But in humans, marked low dose of compound A metabolize a low fraction of compound A and have not suffered renal injury. Effects on systems. Respiratory system, non-irritant, decreased tidal volume in respiratory rate in mild, and increase in PSCO2 at 1 MAC. Central nervous system, preserved contractility, decrease in preload and afterload. For in SVR, no reflex tachycardia, decreased blood pressure. C in the central nervous system, increase in cerebral blood flow, decrease in CMR, reports of seizure in the children in high concentration during induction. So, muscle relaxation, potential neuromuscular block can trigger malignant hypothermia. So, yeah. So these are the main questions will be asked during your preparation of your exams. Factors that determine uptake of IAA. What is MAC? Factors affecting alveolar concentration IAA. Inhalation anesthetic agents. Nitrous oxide current status in anesthesia. Concentration effects and second gas effect. Nephrotoxic of fluorouracil and inhalation anesthetic agents. Effects of sevoflurane on various organ systems. Describe a role of BG and oil gas solubility of IAA. What are the various types of MAC? What is the significance of MAC? Isoflurane versus sevoflurane. So the main question will be knowing before going to the exams. Sevoflurane for the MD exams are sevoflurane, ideal A, dispurane, nitrous oxide toxicity, compressed alpha and isoflurane, minimum alveolar concentration, effect of IAA on bronchomotor tone. Pointing effect is very important. Minimum alveolar concentration and ET and bar. Need for specialized vaporizer for dispurane. These are IV anesthetic agents. A few which we use more commonly are propofol and thiopentine. Mostly propofol will cause minimal of hypotension. This is used for normal all adult patient. If patient having a little BP4 or patient is more cardiac problem, patient is post MUR, post CABG, we use intermediate, which is more cardiac stable drug. And ketamine mostly used in the pediatric age group because ketamine will increase the heart rate and is like a very good drug, which causes no hypotension, no vital changes except heart rate increase. So we use most commonly in the pediatric age group, and for small sedation or small procedures we use ketamine. And propofol is most commonly used anti-thiopentine for patients who have any head injury or cardiac unstable patients. We use thiopentine. What are the IV induction drugs? These are the drugs that when intravenous appropriate dose cause a rapid loss of consciousness. So once you give an intravenous drug, it will like thiopentine or propofol. They tend to cause a rapid consciousness, unconscious state, like it will knock out your conscious level, and it will give a minimal analgesic effect also. And it has a property of sedative and hypnotic property to reduce the anxiety and exert a calming effect, produce drowsiness, and facilitates the onset and maintenance of state of state. On basic circulation time depends on the cardiac output of the patient, ejection fraction of the patient. So the ejection fraction is really good. It will take only minimum of 10 to 15 seconds. Is good. Patient ejection fraction is low, so maximum will take 15 to 20 seconds to drug to get act. So on brain circulation is the time when you give the drug in the temporal nephron and when it reaches the brain. So it's called the time between this. It's called one-arm circulation. So normal range will be 10 to 13 seconds for good ejection fraction patient. If it's like more, patient have very less cardiac output ejection fraction, the cardiac output time when the one-arm circulation time will be little more, like 15 to 20 seconds. So ideal intravenous agents, so they should have a minimum physical properties, so water soluble and stable in solution, stable on exposure to light, long shelf life, no pain in intravenous injection, non-irritant when injected subcutaneously, low incidence of thrombophlebitis, and cheap. Classification of intravenous anesthetics. Rapidly acting primary induction agents or barbiturates, methoxylate, thiopentol. One second, sorry. Sorry. Yeah, slower acting agents or ketamine, benzodiazepines like diazepam, midazolam, flurinitrazepam, and large dose opioids like fentanyl, morphine, alfentanil, surfentanil, remifentanil, and the neuroepileptic combinations or opioid plus neuroepileptic. So these are the properties, physical properties and the effects of the intravenous anesthetic agents. Like you can see, thiopentine, propofol, ketamine, intermediate, methoxylate, the most commonly used among these are propofol, ketamine, thiopentine, sometimes, yeah, and ketamine. Methoxylate is not commonly used nowadays. Yeah, compared to thiopentine and ketamine, propofol and intermediate, they will have the patient or person who getting that will have a pain during the injection. So before giving this kind of drugs, you should give something like oxycodone which act as anesthetic agent. You can give it in the IV. IV oxycodone is available with no preservatives, so we can give that before injecting propofol intermediate, or you can give fentanyl before 10 to 15 minutes of induction by propofol and intermediate. So yeah. So some main silent features of the each and every drug has its own unique properties. Propofol it's most commonly used in all type of anesthesia, but most commonly used for and very good for total intravenous anesthesia, where we use only intravenous anesthesia, none other than that. Like we won't use any airway like inhalation agents or any added spinal or drill. Only we will give anesthesia via intravenous route. So those kind of surgeries will be more useful when we perform under propofol. Intermediate, it has a very relatively less effect in cardiovascular, so it's more cardiac stability drug. So intermediate is used to patients who have a very weak cardiac, very bad cardiac problems. Of course, CABG patients, we use intermediate. Thiopentone will decrease the cerebral blood flow and increase ICP, and that is an anticonvulsant. Patient may taste after giving thiopentone, patient may taste the garlic or onions like taste. And even it has delayed recovery after repeated dose of thiopentone. So ketamine has a very minimal effort. Patients of depression, but one of the main common side effects of ketamine is with hallucinations. Most commonly, most of the patient will experience hallucination, which patient will not know, but we will see the patient experiencing the hallucination. Midazolam is most commonly used for patient who is like coming in seizures. We use as a mildly it has also a mild anticonvulsant, but most commonly used to sedate the patient to give a anti-anxiety drug. Most commonly used like that. And patient who on the ventilator, when the patient who is more elderly and aggressive, to calm down them, we use midazolam. Yeah, so and you can also see the duration of action and the speed of our induction actions. So time it will be the speed of the drug intravenously. The time takes mostly milliseconds, maximum minute. You can see the maximum ketamine doesn't take 1 minute. That's it. Very less than it will cost like 20 to 50 seconds maximum for all that we get react fastly. The duration of action depend upon each and every type. Propofol I will prefer the intermediate or the one which has the least with maximum 3 to 5 minutes. And compared with the little longer time, like 8 to 10 minutes, ketamine little more just edge over the thiopentone. It has like 2 or 3 minutes more than the thiopentone. Midazolam tablet is longer effect, like take 20 minutes. Action will be there for the patient with midazolam. So in induction characteristics and procedure requirements of current level preservative or hypnotic drugs. So yeah, the mainly you should know dosage for thiopentone, propofol, ketamine, diazepam, not diazepam, midazolam, and intermediate. So midazolam 0.2 to 0.4 mg per kg. Propofol 1 to 2 mg per kg. Yeah, you can say 1.5 to 2.5 mg per kg. Thiopentone 3 to 6 mg per kg. Where ketamine we give 1 to 2 mg per kg, intermediate 0.2 to 0.3 mg per kg. So intermediate and propofol has more pain during while injecting the drug. So pharmacokinetic property and pharmacodynamic properties. So it's ideal intervention agent should have a rapid onset and a good one of circulation time, a rapid redistribution to the vessel with a rich tissue, rapid clearance and metabolism, no active metabolites. High therapeutic ratio, minimal cardiovascular and respiratory effects, no histamine release hypersensitivity reaction, no emetic effects, no involuntary movements, no emergency nightmares, no hangover effect, no adrenocortical suppression, safe to use in porphyria. So, what are the mechanisms of action for the GABA receptor alpha 1, alpha 2, alpha 1 causes sedation, anti-retrograde amnesia, and anti-convulsion properties. Alpha 2 cause anxiolysis, muscle relaxation. Propofol is a 2,6-diisopropylphenol. 2,6-diisopropylphenol, highly lipid soluble, contains 10% of soybean, 1.2 of lecithin, and 2.25 glycerol. These are the main contents of the propofol, which is more commonly used question in all the exams. So the content of the propofol is 10% of soybean oil, 1.2 of egg lecithin, and 2.25 of glycerol. Propofol emulsion is an excellent medium bacterial growth. ET or sodium benzoate are added to impede the bacterial growth. So propofol causes pain on the injection. Propofol electrode preparation propofol containing both long and mechanism of action of propofol, activation of chloride channels of GABA receptors, thus enhancing the inhibitory sympathetic transmission. It also inhibits NMDA subtype of glutamate receptors. Onset of action, 1 hour brain circulation time 15-20 seconds. Duration of action 3 to 5 minutes when given IV. Half-life, alpha half-life 3 to 5 minutes, beta half-life 20 to 50 minutes, and gamma half-life 200 to 500 minutes. Inhalation, propofol is metabolized by conjugation to glucocorticoid and sulfate by river. Also undergo extrahepatic metabolism in the kidney and lungs with 30%. Propofol pharmacodynamics in the central nervous system, dose dependent depression of the central nervous system, endpoint loss of response to verbal commands, reduced CMRO2, CBF, and cerebral fluid and intracranial pressure. Can cause some involuntary movements during induction. Central nervous system, it was hypotension, decrease the blood pressure is dose dependent. If you give a more dose, the BP will fall down. So calculated dose should be given and it should be used more cautiously. Most marked by the elderly and in shocked patients can be minimized by slow injection. Respiratory system is transient as apnea, often airway reflects well. Gastrointestinal anti-emetic property also there is there for other effects are euphoria that has been associated with increased dopamine concentration in the nucleus accumbens, a region which is a part of the pressure pathway implicated in many euphoria induced drugs. Anti-emetic property, a bolus dose of 10 mg propofol acid is and this infusion are ineffective in anti-emetic as a result of potentiation of the GABA receptor activity. Propofol also decreases serotonin levels in the area postrema. This decrease in serotonin is likely the reason for its anti-emetic effect. Antipyretic, decrease the purities after administration of spinal opioids. Propofol uses dose and butane routes. Induction anesthesia 2.5 mg per kg in adults, 2.5 to 3 mg per kg in children. Maintenance of anesthesia 50 to 150 mics per kg per minute. Where maintenance anesthesia will be used in the patient who get a TIBA, like total intravenous anesthesia, where we discussed before. So this kind of anesthesia we give a maintenance dose where we use only 50 to 150 mics of kg per minute. Conscious sedation will be given the dose will be 50 to 75 mics per kg per minute. Sorry, please hold a moment. My battery is running low. Sorry for that. Yeah. 1 kg, yeah, for T we can give 1 mg per kg bolus and 10 mg per kg for 10 minutes and 8 mg per kg for next 10 minutes and followed by 6 mg per kg thereafter. Expected to give propofol adverse effects, allergic reaction to egg protein, pain on injection. You should really use a large one. If you choose a small one, it will get what to say, it will be more painful for the patient. Hypertriglyceridemia and development of pancreatitis susceptible for growth of microorganisms. Tubing and NS propofol injectable emulsions should be discarded after 6 to 12 hours. Can cause involuntary epileptic form of movements. Propofol infusion syndrome occurs due to prolonged infusion in small children and infants, usually been used in excess 4 mg per kg per hour for more than 48 hours. Propofol interferes with the mitochondrial mechanism, which is metabolic acidosis and hypokalemia, rhabdomyolysis, renal failure, hepatomegaly and cardiac failure, right frontal branch block and asystole, hyperlipidemia, management of cardiorespiratory support and hemodialysis. So not use propofol infusion more than 4 mg per kg per hour for more than 48 hours. So benzodiazepines, we're going to see more about benzodiazepines now, particularly about midazolam. Benzodiazepines produce hypnosis, sedation, anxiolysis, anti-retroactive amnesia, anti-convulsion property also there, and centrally produce muscle relaxation. Alpha-1 GABA is a receptors modulated sedation, anti-retrograde amnesia, and anti-convulsant. Alpha-2 receptor modulate anxiolysis and muscle relaxation. So alpha-1 and alpha-2 has both different properties, and both as a alpha-2 as a relaxation, muscle relaxation property. So they do not provide any analgesia, primarily used for pre-medication sedation and rarely for induction of general anesthesia and hydrosis. Intravenous diazepam and lorazepam solution contains propylene glycol due to their water insolubility. So, what are the uses and doses of intravenous benzodiazepines? Mostly we use midazolam, but evenly most commonly is midazolam, but we routinely even use diazepam and lorazepam for little older drugs, but still in the use. Midazolam maintenance induction dose like 0.05 to 0.15 mg per kg. Diazepam will be 0.3 to 0.5 mg per kg, and lorazepam will be always a 0.1 mg per kg. For sedation, we use more like a 0.5 to 1 mg per kg. 1 mg we can repeat a dose, a bolus dose we can give. Diazepam 2 mg we can give. 0.5 mg we can give a repeated weight. So this is the molecular weight and pK, water solubility effects, and lipid solubility effects of the benzodiazepines. Pharmacochemical, the pharmacokinetic efforts like a log-like emulsion, clearance, and the plasma protein and the binding of the benzodiazepines. So this is a midazolam. You can see we can get even vial or ampoule form. You can see the right side. You can see the ampoule, on the left side is the vial, where we can see a 5 ml vial is there. Even 10 ml also is available. So each ml contains 1 mg of midazolam. So most commonly available form will be each ml will have 1 mg of midazolam. You can dilute for PRPH2. Midazolam hydrochloride, water soluble with an imidazolone ring in the structure that accounts for stability in aqueous solution rapid metabolism. Solubility of midazolam in pH dependent. At pH of 3.5, imidazolone ring is open and water soluble. At the body pH, imidazolone ring closes, lipid soluble, rapid onset. Availability of 5 ml vials containing 1 mg and 1 ml. So all your vials and ampoules which contains 1 mg per ml. It doesn't cause any pain on injection. Even we can midazolam is only the drug can be given all routes. Even we can give spinal anesthesia, intravenous route, intramuscular, subcutaneous, intraosseous. Almost all the routes you can give. This is the ring sector. The midazolam mechanism of action is activation of chloride channels of GABA receptors, enhancing inhibitor synaptic transmission. Onset of action is 30 to 60 seconds. Duration of action 1 hour when given IV. Elimination metabolized in the liver by hydroxylation and conjugation. The metabolite hydroxyl midazolam has no clinically significant side effect. Induction of anesthesia 0.1 to 0.2 mg per kg IV. commonly used to supplement of the regional anesthesia for sedation. For pre-medication, those also for pre-medication before general anesthesia, it's also used at 0.5 per kg. Popular drug for sedation, critically ill patients in ICU are most commonly used, and for midazolam because even they won't cause any prominent hypotension or tachycardia. But if you give more dose, it may cause a respiratory depression and also act as an anticonvulsant drug. So midazolam, pharmacodynamics, or CNS, so those different depression of the central nervous system and say the cardiovascular system, relatively cardiostable, doesn't affect heart rate and BP much, as I said before. But if you give more dose, it will may cause a little bit of respiratory depression. Caution: it should be used in the patient with the hypovolemic as may aggravate hypotension sometimes. So most commonly used questions in the MD example comment about the steroid anesthetic agent, the intravenous anesthesia and its clinical application, difference between a type and propofol, use of flumazenil and its dosing schedule. Flumazenil. Write briefly about propofol, pharmacodynamics and dynamics, dynamics of 5-penton. So effective on DNP questions like will be a mechanism of action of pharmacodynamics of propofol, effect of propofol on various organs and its clinical uses, total intravenous anesthesia, PK and PD of intermediate role in anesthesia, pharmacodynamics of thiopentone, propofol versus thiopentone, three compound model of drugs, distribution, zero order kinetics. Thank you so much. Hope you enjoyed